So welcome. Thanks so much for joining this open show and tell. We'll introduce ourselves, or Ian will introduce us in a minute, but I just wanted to say hello. And this is a show and tell with TPXimpact and Buckinghamshire Healthcare NHS Trust. And this is just going to cover a discovery we've just finished, where we've been talking to patients and staff to really understand their experiences and the challenges that they face to help Bucks NHS Trust to really improve the experience across their patient pathways. So we've got plenty to kind of go through today. And the agenda looks like this. So this is what the next hour looks like. We'll be speaking for about 45 minutes. So what we'll do is we'll introduce the team and give you some background to the work, just to kind of set the context for what we've been up to and why we've been doing it. Then we want to describe a little bit about what we did and what we discovered, so what we found out. And based on these findings, we'll talk a bit about the recommendations we've made to Bucks and the kind of opportunity areas where changes can be made to improve that overall experience for patients and for staff as well. And then finally, Ian from Bucks will briefly describe what's happening next with the work as well. So, and you can see kind of what's coming up. And then that's your chance to ask questions as well. So we'll have about 10 minutes, something like that at the end, that you can kind of ask us some questions. In the meantime, if you've got questions as we're going through the presentation, feel free to drop them into the Q&A button at the bottom of your screen. And that what we can then do is come back to those at the end of the session and pick those up as part of the Q&A as well. And if there are some things that we can quickly respond to, we'll be doing that as well. And finally, just before I hand you over to Ian, I just want to say that at the end of the show and tell, we'll be sharing, during the show and tell, we'll be sharing some links to some of the original material that we'll be talking about, so you can go and have a look at that in your own time. And then what we'll do is at the end of the show and tell later this week, we'll send you the final report and the recording for the show and tell as well. So there'll be contact details on that, on this deck and on the report as well. So if you want to follow up on anything, you're very welcome to drop us a line. Ian's the interim Chief Digital Information Officer at Bucks ICS. So he was our kind of our lead for the work, and he was joined by Julia as well. So we worked as a blended team. So rather than kind of us going into Buckinghamshire and doing the work to them, we worked as one team. I led from the TPXimpact side of things. So I'm a principal consultant, helping lead the work and the team to kind of deliver in line with the client's expectations. And I was joined by Gosia and Dave, who's our senior service designer, Hannah, who is our design researcher. So Hannah did a lot of the research with patients and staff, and Mo was our technology lead. But I think one thing that Ian would probably want to really stress was, again, we didn't do this as a kind of blended team alone. We worked with over 75 colleagues from across Bucks, the trust, and that was colleagues, staff from the gynecology pathway, clinical pathway, cancer, the digital and technology teams as well. So it really was a kind of team, a whole team effort. So I think Ian as well was really keen to just say a huge thank you. I think we couldn't have done this work without the participation, the input from colleagues and staff at Buckinghamshire, as well as the patients as well. So Hannah and the team will talk a little bit about the number of people that we spoke to and the kinds of things that we discovered. But ultimately, these are complex pathways. These are clinicians and members of staff under huge amounts of pressure, and patients going through often complex and kind of serious issues. So for them to take the time to kind of step out of that and talk to us and really help us understand their experiences and what's working and what's not working was incredibly powerful as well. So that's a thank you to them, really. I just wanted to very briefly just give you some context to the work, really. So just kind of what we were trying to achieve with the work, you know, why Ian commissioned us to come in and really kind of undertake the research. Ultimately, Buckinghamshire Healthcare NHS Trust has a real ambition to create simple, consistent and integrated experiences for its colleagues and its patients. So that's for staff working within the trusts and the patients that are navigating across those different pathways. And really, it was an opportunity here for Bucks. Bucks undertakes millions of kind of patient interactions each year, so patient contacts each year. While the majority of these are very positive experiences for the patients, for staff and for clinicians, Bucks really recognised that there's always an opportunity to kind of do better and learn from the things that aren't working to really make sure that those experiences are as good as they possibly can be. And so what they asked us to do was work very closely with the cancer and gynecology pathways as a way, as almost a kind of window into that wider patient experience across the Bucks pathways, to really explore, you know, what was working, what does it feel like to be a patient going through those pathways, where are the bits that really work and where are the bits that maybe there are challenges or that aren't working so well. Based on those areas that aren't working so well, really use those as an opportunity to learn lessons that can be applied across the trust as a whole. So that's what we did. I'll hand over now to Dave, who I think is just going to talk a little bit more about the goal of the work.
Yes, hi everyone, good to meet you all. So I'm Dave, I'm a senior service designer on the project, and I'm going to be talking a little bit more about what we're focusing on. So before this project, Bucks had conducted sort of research into patient pathways, but from an organisational perspective, you know, what activities are done, what processes take place, what systems are used, but not so much, as Ben said, was known about the patient experience, their journey, their needs, the interactions they have with the service and the challenge they face. So our discovery was really focused on this, particularly from a comms information provision perspective. And this was important because researching this patient experience meant we could build an evidence base for change, so we could make changes to the communications and the information provision aspect of the patient experience, which should hopefully improve the experience for both staff and patients, reduce risk, increase productivity, and improve outcomes for everyone. One important thing to say was, you know, this work was sort of not to be used as an evidence base for assessing a change in clinical practice across the pathways. It's specifically on sort of comms and information provision, but of course all the insights that we've got sort of shared, so they can be used by clinical teams if they need them. So by default, sort of TPX and more broadly across the NHS, we sort of use human-centric design practices as our sort of default. And on this project, we wanted to adopt a deeply human-centric approach to the project. We really wanted to put patients and their families, and not just them, but staff as well, at the centre of our research and design. And what this means in practice, quite simply, is we want to focus on the patient and staff experience, understand the challenges they face and the needs they have. Where possible, we want to co-produce solutions with them. So we're making sure we're designing the future with them and not for them, and also be very scientific in our approach. So be hypothesis driven and test ideas with real users. So we build an evidence base for the change that we want to make in the future. So on top of human centricity, there was a number of other principles and ways of working that we wanted to make sure that we sort of lived and breathed throughout this project. 3 in particular. So number 1 is we wanted to work in a really agile way. Sort of, I'm sure on this call, like, we're all familiar with the waterfall approach. We wanted to go in a different direction. We wanted to be agile and iterative. And what that meant in practice, we wanted to be open as well. Sharing as we go, engaging with different people and showing sort of our work as we progress and get feedback on it as well. And finally, we want to be digitally collaborative. So patient experience involves a lot of different teams. We wanted to bring those teams together using digital platforms to make it easy for us to collaborate and share different perspectives. So I'm going to spend a little bit of time talking about our approach to research as well. All good research starts with seeing what's out there already. With our project, we started off with conducting a literature review, some desk research, because there's been a huge amount of work done in these areas by the NHS, Royal Colleges, Buckinghamshire Healthcare Trust teams themselves, and the voluntary and charity sector enterprise organisations as well. We really wanted to learn from these insights before conducting our own research. This involved looking at different reports and looking at patient stories on social media and synthesising a set of insights that we could use to do the following. Understand what the common patient journey looks like for these pathways. Think about what sort of challenges have been recorded anyway at a national level that might also be relevant for Bucks. Also to help us develop a set of hypotheses for our primary research that we can explore through conducting interviews and the other activities we'll talk through later, but also look at what good looks like. So we have some ideas that we can test throughout the course of our research. Now, I think Faye will be making links to the desk research available as we go through, so please do take a look. There's some really interesting stories in there. Just as a snapshot of some of the things we discovered, for gynae, we discovered that patients struggle to access the right information to help them identify what potential conditions are and how to manage their symptoms over time. And for cancer, we discovered that patients expressed that after treatment, they realised the emotional journey was actually really tougher than they thought it would be on reflection, and they wanted more information and guidance on accessing emotional support. So please do take a look through the links. Some interesting reads there. Just a brief note on the sort of scope of our research. So our discovery was focused on patient experience, understanding that. As many of you know, patient experience is so inextricably linked to the service itself, you can't really look at it in isolation. It's made up of lots of perspectives and is very layered, and we recognise this when we start. So to get a clear view of the different factors that impact the experience and make sure what we were giving was actionable, with a clear view of where you can make a change to the experience. We didn't just explore the patient perspective, so the front stage. We also spoke to staff and the different workforce that are involved, clinical colleagues, administrative colleagues, and digital back office teams to build that rich picture of what the pathway looks like. How exactly did we engage with staff? To build that rich picture, we conducted 4 different research activities. Number 1, a technologist workshop, where we basically got a large number of the digital back office teams together and held a wide-ranging discussion and ran a mapping exercise just to look at what different systems might be involved across the pathways for cancer and gynecology, identifying different challenges and potential lines of inquiry for future research. We also ran 2 specific workshops with cancer and gynecology teams, where we mapped, thinking about specific scenarios, the different processes that are involved from presenting your symptoms to being discharged, and what systems the staff used during those processes, and the different challenges they might face because of those systems. We also ran a number of one-to-one interviews just to dive deeper into the system landscape, which is really useful. And then we also ran a staff survey to gain a broad insight into what are some of the systems that are really causing problems for staff, and what might be some ideas to improve their experience. Cool. So for patient research, we took a similar mixed methods approach. In terms of who we spoke to, we looked at speaking to currently or recently discharged cancer or gynae patients, and with input from BHT for cancer, we focused on lung, prostate, breast, and gynecology tumour sites. And for gynecology, we focused on speaking to any patients who have experience of any gynecology conditions. We also looked to speak to some patients who had been discharged in the past 5 to 10 years to understand what the long-term experience after treatment was. In terms of the activities we did, we've got 4 separate ones here. We looked at large swathes of friends and family test data that was patient feedback for cancer and gynecology services. We engaged around 25 patients in rapid interviews, surveys, and a pathway mapping activity in a pop-up Wickham Hospital. We also conducted 8 more in-depth interviews with patients from cancer and gynecology pathways who reached through word of mouth and local support groups and social media. And we also distributed a patient survey at in-person clinics via social media at Nextdoor application as well, and got around 139 responses from patients. Cool. So what happened after that? We completed our research and we'd synthesized it. After doing that, we held a co-design workshop with the digital and technology teams to basically do a deep dive into our findings. We shared our patient journeys that we'll talk more about later and be sharing with you as well, and asked them to react to them in terms of, what do you think about these different insights? What are some potential lines of inquiry or hunches that you might have for the root cause of these issues? After doing that, we also worked with them to go, okay, we've got all these different opportunities. Let's prioritize them, consider them in terms of like how impactful they might be to solve and how difficult they might be to solve as well. That was the main focus of the session, and the output of that was a Kanban board, which you can see here on the left, which provides a prioritized set of opportunities to continue with.
So as Ben said, I'm the design researcher on the project, and we had the privilege really of speaking to patients and listening to their experiences. I know that some of them are here today. I just wanted to say thank you again for giving your time so generously to support us in this research. So after speaking to patients, we synthesized what we'd heard. We were looking for common themes. And then what we did was to focus in on kind of key actionable insights that highlight really specific challenges around communications and information provision that we felt have kind of real potential to improve the patient experience if we can address them. And just before I launch into those key insights, I wanted to just note I might share some potentially distressing content that some people might find a bit upsetting. So the first thing I'm going to talk about is the cancer insights. So the first insight was that patients become distressed when expected timelines are not met. Information provided to patients on, for example, how long they should wait before their referral, or kind of following diagnostic tests, how long they should wait to hear back, are often inaccurate. And that causes patients to become very distressed and to try to contact the hospital to understand what the delay is. So we've discovered that patients find it helpful when realistic expectations around communications are set. And during long wait times, patients would like regular check-ins so they know where they are in their journey. Next insight was that patients are experiencing challenges around appointments. Patients often receive communications around appointments via letter, often second-class post, which sometimes arrive at very short notice or after the appointment has already happened. If they have multiple appointments, they can be double booked or scheduled back to back in different hospitals. Patients have also found the letters to be confusing sometimes. They don't include enough information about where to go and what will happen. Sometimes patients show up to appointments but find they're not expected, or the appointment has changed without notice. So the insight there is that patients really want timely and clear communications about their appointments so they can attend them without challenges. Receiving a diagnosis is a key moment that matters to patients. During a diagnostic appointment, patients can feel overwhelmed, cognitively impaired, and alone, understandably. It's really important to patients to be able to bring someone to their appointment to give them support, but it's not always clear if they're allowed to do that. And I know that during COVID, that was a particular challenge with changing rules. Patients want a record of that conversation so they can revisit it to help them process the diagnosis. And they want to ideally be able to follow up and ask questions after the appointment, as they're often unable to do so at the time. Patients want resources, but the current provision is not meeting this need. Patients feel that the current resources provided are a bit too high level. They don't offer enough guidance on practical points like meal plans or where to buy a wig in the local area, how to access supplementary therapies. Patients want information about their condition, treatment options, procedures, side effects, and aftercare from, really importantly, a trustworthy source. And they want to be able to access and return to that information easily. They want the information to be provided at the right time so they can be prepared for every stage of their journey. Patients feel relieved after being discharged, but want a clear line of communication in case of relapse. Even 5 years after their treatment, when they're discharged, patients are anxious about their cancer returning. And some feel like they're discharged without direction, having to kind of rely on informal sources of information about things like changes they might need to make to their lifestyle, things they might need to look out for. Patients want more support and guidance after being discharged, and to have a kind of clear line of communication to contact the trust quickly if they have a concern. So these are our key actionable insights from the gynae pathway. So insight one, patients are experiencing lots of challenges around referrals. It often takes many visits to the GP over a long period of time for patients to be referred to specialist primary or secondary care. Patients find the various pathways they might follow in that very early stage of their journey to be really unclear and confusing. When they do receive a referral, patients experience lots of challenges around communications between primary and secondary care, such as issues around forms required for each service, and that can cause further delays and increase patient distress. Patients don't understand why they're unable to get an appointment with a gynecologist. Patients are really struggling to make appointments after being referred by their GP. There can be very long wait times with very little information about where they are in their journey. Patients are also sometimes given conflicting information. They're told they should expect to have an appointment in the clinic after undergoing tests, but they're then informed that no clinics are happening without much explanation. So we really felt that not much guidance was given to patients on when they're going to be able to move forward, which is causing really significant frustration. We found that teams across settings and departments don't always have a full picture of the patient. The insight there was really that many gynecological conditions affect patients over a really long period of time. They're not such a clear linear path. So patients said they often don't feel like their care is joined up. Clinicians are sometimes unable to access their history or test results or scans during appointments, and things like admissions to emergency care are not flagged to other healthcare providers that they might be seeing. Patients really want staff across settings to be able to really easily access their full medical history so that they feel like they're moving forward with each interaction instead of starting from the beginning every time. Patients need more support to manage their pain. We found out that patients with gynecological conditions often experience severe, debilitating pain over a very long period of time, but it can take a very long time for them to receive a diagnosis and access any treatment. Patients don't feel like they have enough support or information about how to manage their pain while they're waiting, and that pain can cause patients to feel like they've reached a crisis point where they feel unable to function. So we really felt like we could support patients to have more guidance and support around how they could manage that pain while they're waiting for diagnosis and treatment. Patients want more channels of two-way communication. They don't feel like there's a way to contact their consultant, and when they have questions or concerns, they don't know who to speak to. And that was quite different to the cancer pathway, where there is quite an infrastructure around nurses that patients can quite easily reach out to, and it felt like there was a real disparity in those two pathways. Many patients kind of really struggle to book reviews or follow-up appointments after undergoing a procedure, which can leave them feeling uncertain and alone. When they're given a number to call, sometimes that information is out of date and leads to a dead end. And sometimes patients don't feel that the current feedback channels that exist really give them the opportunity to share their experiences. And sometimes when they do give feedback, they don't feel like it gets to the right people at the right time.
Hi, my name's Mo. So I was the technology lead on this project. So we wanted to paint a clearer picture of the patient experience, but from the workforce perspective, as we believe this has a bearing, of course, on the patients. So we wanted to understand and capture those different pain points experienced by the workforce, focusing where there is any direct impact. So on the following slide is a compilation of the different insights. The larger points reflect what has been commonly referred to us amongst the different team interview sessions and discussions that we had. So you can see systems not being linked and the manual work involved in the using of systems are two of the bigger points. I know just stating systems is a bit vague, but what we are generally referring to here is having to move between multiple different system types, which has a negative impact on effective patient management. So admin and clinical teams spending a significant proportion of their time accessing these different systems, then reducing the time they have to spend communicating with patients or delivering patient care. And in some instances, hospital systems are not accessible by teams in other sites, so that kind of causes further roadblocks, especially when patients move between those different hospitals. So this one, it's a more direct patient-related issue, but one that teams experience challenges with, is incorrect information contained in letters to patients, which more often than not, they have little control over. Often letters contain incorrect phone numbers or appointment details. Medical terminology can be misspelled, and facts presented in detailed doctor's speak as opposed to layman speak. And even sometimes when the letters have low grammatical accuracy. So one of the things from the discussions that came up has been highlighted to us is these issues may relate to the letters being produced offshore. And so when patients communicate and express these challenges to clinicians or administrative teams, they can feel helpless and slightly demoralized. So a significant amount of that time is spent solving these communication challenges for patients. One of the recurring issues for teams and technologists is that requirement for manual intervention in a lot of the systems they use. And what we mean here is when these different systems require manual data searches or access to patient history to understand where that patient is at in their healthcare journey, but having to go through this search via multiple different systems adds to the manual workload and really kind of decreases efficiency. And in some cases, this overhead is required because there hasn't been a transfer of contextual written data, such as patient notes being fed through to other applications. So next slide, I'm just going to quickly hand over back to Dave to talk to us about the journey maps.
We've spoken about a lot of different insights. What we did as part of this project to illustrate what that experience looks like for cancer and gynecology pathways is we created 2 very rich patient journey maps that are basically a synthesis of all the different things we heard from patients, we heard from staff, and we learned. We're not going to go through them now because they're big, they're rich in data, and they're well worth going through on your own. But we are going to share a link for you to go through. Just a quick summary of what they are is that each map tells a story of a patient as they go through each step of their healthcare journey. The patient, the scenario, and the steps are fictional. They're all informed by real patient experiences, but everything else in the map, so the quotes that we see, the needs, the pain points, and the impacts, they're all real from conversations we've had with patients and staff. So highly encourage going through those and looking at those stories and reading through them, as they're really insightful. Next slide, please. I think Mo's going to jump back to quickly introduce recommendations.
Thanks, Dave. So a transition to recommendations. Discoveries aren't often about recommending solutions, but we were keen to give back some tangible actions that could be started and tested. So after researching the patients and workforce experiences and synthesizing issues into those journey maps that David just alluded to, we then focused on how we might address them. And we focused on 2 parts. Quick wins and also opportunity areas to work through in the future to address the challenges patients are currently experiencing in their pathway. And I'll let Dave talk about the opportunity areas, but first I'll just quickly take on quick wins. So we've compiled a set of initiatives that we feel could be quickly explored, tested, evaluated, and then delivered. And our hypothesis being that these solutions could have a positive impact on the experiences of both patients and the workforce, where the solution is somewhat known, making delivery potentially a bit swifter. So I can go through a couple of the top ones. I won't go through all of them. But yeah, so the top one, a key pain point has emerged around the information contained in patient letters, as we discussed, or I discussed a bit earlier. So fixing those common errors on letter templates could make it easier for the patient to navigate their clinical journey. And we think a review and update of this information can have a fairly immediate effect on the quality of patient communications. Another one, letters being sent to patients are not always available in digital formats within a dedicated patient portal, not for every pathway anyway, and therefore this limits patient access to communications, and that would need to be consumed at different stages of their journey. So giving them access to a digital portal can really improve that patient experience. A portal that could take case notes from different systems like CareFlow, and that shares that data, can help them as they navigate their care journey. So back to Dave again, just to talk through the opportunity areas.
Yeah, that's me, and I'll try to do this quickly in 5 minutes. There are around 45 opportunities in total that we shared with Bucks, or hypotheses about what we think can change. We will share that after the event, but we've got 3 from each area, cancer and gynae, just to go through now. What we've got here is the insight on the left and the hypothesis on the right about what we think needs to change and the impact that it could have. So the first one for cancer was that referral letters and the information on there isn't always accurate. It causes patient distress and means they could contact the hospital multiple times. We believe that if we fix that and give them the correct details, they can arrive on good time, which means that patients don't spend time having to contact the hospital to get the right details and have reduced anxiety around referrals. So this one is a really powerful one from our research, and it's that during diagnosis of cancer, people can feel really overwhelmed, cognitively impaired. You don't really take information on board, which can make it difficult to cope. Our hypothesis is that if we give those patients the ability to have all those different details they might get in a diagnosis, maybe through a recording or through some written notes that are attuned to patient needs, we can help patients to feel more clear on the details of the diagnosis, sort of ease their distress and make the outcomes at the beginning of their journey better. So for cancer, we've heard that for patients, their treatment finishes and they're sort of discharged, but they feel like they're discharged without direction. They do sort of the best they can, but they feel unguided or don't know what to keep an eye on. And we sort of hypothesized that if we provide better guidance for post-treatment life, sort of what to look out for and what to be worried about and what not to be worried about, we can help patients to sort of safely manage their own health and reduce those times that patients will contact the healthcare service where it was avoidable over something they didn't need to be worried about, which would help to reduce anxiety as well. So for gynecology, early on in the stage, we've heard that patients really feel left in the dark about when appointments are for the gynae clinic. There isn't really much explanation as to why either, which can cause a lot of distress because people don't know when they're going to be able to speak to a specialist. Our hypothesis is that if we can provide sort of greater transparency over when a gynae clinic appointment might become available, and any sort of rationale as well for long waiting times, which are expected in sort of elective recovery phase for healthcare services, it can help people to feel more confident about their appointment, reduce their anxiety, and hopefully sort of reduce the amount of demand they have on healthcare services and build up to appointments when they try to find out more information. So we've also heard that patients with gynecology conditions experience huge pain and discomfort whilst they're waiting for diagnosis and treatment, and there isn't really enough support, be it information or services, to help manage those. Our hypothesis here is that if we provide more details on how to manage those really severe systems and signpost to sort of existing support services, we can help improve the quality of life for patients during this phase, help them to manage their symptoms effectively. We also heard from patients that like the full extent of the different diagnostic procedures and treatments for gynecology conditions and potential side effects wasn't always made clear to patients, which can create a really difficult experience. Our hypothesis is if we can provide more details on what to expect during those procedures and treatments and how they can best prepare for them, either like logistically or emotionally, that should help patients to understand what is normal to expect, come prepared in the right way, and provide some emotional support as they go through those procedures and treatments. And I believe now I'm going to be handing over to Ian to talk about what is next.
I did want to reinforce the thanks to the patients and colleagues who've helped with this work, particularly as sometimes it can be shining a light on a service and folks really care about their clinical service. So I really want to reinforce this is not about the individual services. The services we've talked to are both critical, but also quite complex from a patient journey point of view. No patient journey is linear, and particularly in gynae and cancer, you can go to different specialist areas, to diagnostic systems, to how you manage your appointments. So these two were exemplary pathways in terms of the service they deliver. There are many millions of excellent patient experiences, touch points, and what we're doing here is trying to learn from those where we know we could do it better. So, and we're also testing out, I think, as we talk about this approach, how do you do aspects of user-centered design? How do you do research in really sensitive areas? These are patient journeys that folks have gone through. And then from my point of view, what I'm trying to do in the trust in terms of doing digital, how do you build an agile mindset? It's always a challenge, balancing business as usual, keeping the lights on with working in an agile fashion. But I'm determined to give it a good go. And that means, as you've seen, building a backlog. The NHS is challenged in many different ways. Pressure on services, resource, whether that's money or people. And there's always far more to do than you have time to do. So rather than just putting stuff on a list, we're starting to build backlogs. We're using Kanban boards. We'll be growing our approach to prioritization, estimation, and using that across the trust to help folks understand the pressures and the priorities and have a whole trust joined up view of where we should be focusing our effort. And particularly the estimation would be very much looking at those things that might be a small task but could give medium benefit very quickly, as opposed to those things which may be very big tasks but may take a long time and you don't get your benefits. So in terms of what's next, we're on a digital journey. We'll be looking to significantly accelerate our EPR world. And if you know about HIMSS levels, we'll be looking to accelerate through that and support the government agenda in terms of levelling up and convergence within the ICS. We'll be looking at this backlog to see what can we do immediately, either within colleagues or with colleagues within the trust, maybe see if the ICS can help. And potentially look for ICS-wide solutions such as patient portals or ways of managing outpatient appointments. And then there's probably just little things like changing the phone number on a letter, not least because we've got soft phones. So that's kind of what next.